I would like to request Dr. Krishna Kanta Roy with his presentation on ERM removal. So this is going to be a basic presentation on ERM removal, and Dr. Krishna Kanta is a VR consultant at the Divita Eye Institute at Durgapur, and he's a prolific VR surgeon, and having done his fellowship from Shankar Nitralaya under Dr. Dhanashri Ratra and others. So welcome, Dr. Krishna Kanta.
Thank you, Dibul sir, for the opportunity. Today, I am going to discuss ERM removal from a young surgeon or beginner's perspective. So before going for surgery, we have to plan the surgery and pre-operative assessment. So in that, pre-operative OCT is very, very important. As a few ERM, they are very loosely adherent, very easy to peel, whereas few membranes are there, they are very much adherent to the retina and very difficult to peel. In these cases, choosing the peeling instrument is very, very important, as the for initiating that ERM peeling is required much more force. So using forceps is a better idea to start the ERM peeling. Second, in few cases we can see that ERM margin very well. Like in the first case, here you can see that ERM margin and which is slightly elevated, so it is very easy to feel. But in second case, it is very difficult to see the margin of this ERM. So this is correspond with the intraoperative findings, intraoperative fundus findings. So here we can see the margin very easily. We can start the peeling, but here it is very difficult. So here we can use another multimodal imaging like blue reflectance. As you know that in blue reflectance, from the blue reflectance, we can use that superficial retinal structure very well. So both the cases we can see that ERM margin a little bit more clearly than the fundus picture. So here actually we can see the delineate that margin of ERM. So some cases this multicolor imaging also little bit help us to see the find out the margin of ERM. Second, if its cataract is there, especially posterior subcapsular cataract, we have to remove that. And instrument, yes, we have to use that. Now the era of 25 gauge, we prefer to use the 25 gauge instrument. And viewing system, yes, we can use the biome and contact lens both, but contact lens have little bit advantage over the biome, that contact lens give us a better visualization, more magnification, and especially in myopic patient, using instrument with biome is a little bit difficult, where contact lens help us. Third, in high myopia, if a patient has high myopia with epiretinal membrane, in that case choosing instrument is difficult, is important. We have a membrane peeling forceps and a scraper. Scraper have a little bit more reach than the forceps because length is a little bit more. So we can start the surgery from scraper. Now this is vitrectomy. So in vitrectomy, actually we start do the core vitrectomy. After that we induce the PVT with help of IVTA. Though 70% cases if PVT was there, but few cases vitreous is very much adherent to the over the membrane. So we have to take care. We have to pull gently. Next. Visualization aid, we can use the some stain like Timsolone or Milan blue dye. So Milan blue dye give us a negative staining. So initiation the peeling. So we can use two instruments. Like previously we used other instruments also, but right now we are using mainly these two: membrane peeling forceps and membrane scraper. So membrane peeling forceps mostly we are using for where we can see the margin, where it is a little bit difficult to start the peeling. But a scraper, which is a ERM is very thin, and we cannot not very much sure about the margin, and especially for the beginners to prevent the damage of underlying nerve fiber layer. So in forceps, we normally use pinch and peel technique. So align the forceps over the edge of the margin, then we first pinch, lift and release. So this causes loosening of the epiretinal membrane, like you can see here. And after that, again we pinch and make a flap. And then we pull that flap tangentially along the retinal surface. We should not pull vertically over the retina. So we have to pull that flap along the retinal surface and maintaining the curvature of the eye. And second thing is we have to extend the flap circumferentially, like we do capsular excess in cataract surgery. Otherwise it causes break in other area. Now this is the pinch of peeling technique. So we first pinch release, and then again we pinch, then we start peeling. So here one nick is there, then we can see the margin, we can hold the margin of the ERM and we start filling, and gradually over the retina and circumferentially. And another thing, we have to hold multiple times. We have to see one go, we should not go that, we should not remove the membrane entirely, that may cause break in other area. So this is another video, same thing. We first pinch, release, and then again grab and make a nick over the membrane and hold that margin of that membrane and gradually start the peeling over the retina. So here we can use membrane scraper. So cases where we cannot see the margin very clearly, or we are not very much sure, especially for the beginners, we can use the scraper. With membrane scraper, we can move over the membrane and make a flap so that is little bit elevated from the retina. Then we can hold it with forceps. Now I am holding it with forceps and try to peel, like pitch and peel technique. Now ILM peeling, it is a little bit controversial to ILM peel or not. Yes, it is multiple papers show that ILM peeling does not improve the functional outcome, but it decreases the recurrence, chances of recurrence. So in most cases we do ILM peeling. So after staining with brilliant blue dye, so you hold that ILM, already the nick is made and it is elevated from the surface. Then gradually, like ERM peeling, membrane peeling also done. So in summary, preoperative assessment with OCT is important. Sometimes we can use help of multicolor imaging also. Yes, visualization with triamcinolone and brilliant blue dye is good, which help us for surgery. And initiation of peeling with forceps or membrane scraper can be done, but continuation of peeling done with forceps. And ILM peeling normally we do with forceps. Thank you.